This is an overview and an explanation of how the subcutaneous injection station may appear in the OSCE for you. And we have got some, as I've mentioned in some of the other videos, some insider information from the examiners of exactly the scenarios and how they may appear. I'm going to give you a scenario of a child that's getting a subcutaneous injection, but also if you're getting adults, it's very, very similar and there's only very slight differences, and I will point them out as I go through this, and we have got the demonstration videos to watch. So you may well get a child in paediatrics who is a 13-year-old, and this patient may have just had spinal surgery and had a spinal fusion for scoliosis a couple of days ago. Now they're post-op and have reduced mobility, they've been prescribed the drug enoxaparin to prevent thrombosis. And the scenario will be telling you that they're having this twice a day prophylactically, and the patient, Charlie, has already had a dose this morning, and it's telling you that you're going in to give the evening dose. He is accompanied by his father, who has parental responsibility and has provided you with consent. So you may get that drug, but we also do know in the OSCE for children that you may get the drug adalimumab, which is a drug used for juvenile arthritis. It's also a subcutaneously injected drug, and these both come pre-prepared. So I'm just going to give you a little bit more information about that, and also how the exam will unfold. So in this station, the examiner is working from a script, and they will be telling you that this is a subcutaneous injection station, and they will let you know that it's a 12-minute station, and that they will warn you when there's 5 minutes left. And they will then show you the equipment and explain what is expected of you. And they'll state to you that before you administrate the drug, you must complete all the required checks. And this includes checking the patient's identity against the prescription, and also checking the prescription thoroughly using the 7 rights. This is a community prescription that they have been using in the OSCE for subcutaneous and in adults IM injections. So they are a little bit different from the hospital charts. You still have to do the 7 rights, and we do see people failing to do the 7 rights in training, but by the time they finish their training, they usually are quite aware how important this is. But we do need to know what the 7 rights are to start with. So it's the right patient, the right drug, the right dose, the right date and time, the right route, doctors signed it, and they're not allergic to it. So you need to be able to say all these things, and then just mention that you're happy to use the chart, that it is valid and correct. So without doing those checks, you cannot pass the OSCE. Without doing a full ID check with the patient, you cannot pass the OSCE. So you need to mention to the patient, or if it's a child, you need to be asking the parent what the ID is. Okay, so what if the child is of a certain age where you think it may be okay to ask them? You can just say to the parent, depending how old they are. For this patient, we've picked a child that's about 8 or 9. So if the child is 8 or 9, and in the exam, like we said, that scenario, the child was 13, I think I would always ask the child their name and just and also say to the parent, is that correct? If a child's 13, I think to establish rapport with the patient, we should probably be asking the patient if they have normal cognition and no learning disability. We should be asking the child really their age and checking it, and also their date of birth. But you could just, as a to be absolutely sure, you could ask the parent to clarify that. And then also the allergy status, you'd probably ask the parent as well to clarify they have no allergies. When we're doing a check with a community chart, we're going to be checking the patient's first and last name, where they live, their date of birth, and as I say, their allergies, and that's a full ID check. Without that full ID check, you cannot pass, okay? So once you've obtained all that information, you would then go to prepare your medication. So you're going to be preparing this at the bedside of the patient. The reason for that is you can, if you're doing the adult OSCE and you need to draw up the medication using the syringe, you're drawing up the medication from the, usually it's a blood bottle they're using in the OSCE centres, even though normally, obviously, it doesn't come in a blood bottle. But the similarity is the rubber bung is similar to the rubber in the blood bottles. So we need to inject into the blood bottle and withdraw the medication. Once you've done that, you can't resheath the needle. So that's why I'm saying you need to be next to the patient. They did used to allow us to resheath needles. In fact, it was in the criteria that you did resheath the needle, but best practice changes over the years. And now in the UK, they do not condone resheathing a needle. So it would be a critical mistake. So now we will prepare the medication. So the examiner will also explain to you that although I am not preparing this medication with you, I would like you to show me your injection prior to you giving it. In the community, we don't check insulin as a rule, as a double check, unless in your place of work that is in the protocol, a drug administration protocol. But in hospital, we normally do double check insulin. But in a community setting, and we're being told this is a community setting, we're not going to double check insulin. And so the examiner is just basically saying to you, I want to see how much that you've drawn up. And I will say that during our training sessions, I very often see nurses who, when they are preparing for adult OSCE, who are drawing up the wrong amount of medication. So please do be aware that these syringes are 100 unit syringes. Therefore, they have increments on both sides of both sides of the syringe itself. So you've got 15, but then on that mark, the dark mark, but underneath it's got a little mark on the right hand side of it for 16, then on the left hand side of it for 17, and so on, and it goes like that. If you get a 50 unit syringe for insulin, it has it all the way down just in the increments on the same side as the mark for the number. And that means that if you're not used to using these 100 unit syringes, you may not realise, and then you typically will draw up too much medication. And this is what I find when I am practicing with the nurses, and I've been doing this insulin administration for many years in the OSCE training, so I've seen this week in, week out. And I'd like you to get used to the syringes and how to use them correctly, because if you do draw up the wrong amount, the examiner may not at all prompt you to check it. They may just assume that you were incompetent and unable to give the drug at the right dose. So that's what they're checking for. If you are a children's nurse and you get a pre-prepared syringe, do remember, so say this was Ali Mumbab, it may have an air bubble in it. So you'd be expected to knock the air bubble out. You don't even have to take the lid off when you do it. Obviously you're wearing gloves and apron, PPE. And you're going to just squeeze out any extra liquid and get it up to 20 units. And then the examiner is also going to be checking that. So I hope that's quite clear about how to prepare your medication, because it is a critical and we do want you to pass this and get the right amount. So, as I said, those checks are very important. Checking the drugs very important. We teach you to check all the equipment and all the stuff that you're using. So this is gauze swabs, and we would like to see you checking for the expiry date, which is there, and it's actually like a little egg timer symbol. So that is the expiry date. There's also a factory date, which is when it was manufactured. Some people look at that date and always tell me I've got expired equipment, but that's actually when it was manufactured. So please do know the differences. This is a alcohol swab, and again, it does have dates on it. So you're looking again for the egg timer symbol, and do check. It gives extra reassurance to the examiner that you're competent and you're safe and you know what you're doing. Why are we using alcohol wipes in a subcut injection? You might be wondering, because maybe you're used to giving subcut injections and you don't clean the patient's area. So it's not actually completely necessary to clean the skin when you're giving injection, so best practice tells us. But if a patient was dirty, if you felt that the skin was not clean, you would be expected to clean it. The other times that you would clean a patient's skin is if they were suffering from a condition which affected, they were immunocompromised, such as HIV, neutropenia, if they were on workup for a transplant and their immune system had been lowered deliberately. So in those circumstances, you would clean the patient's area. But if the patient was dirty as well for any reason, of course, we would clean the area. We do teach you to say that the skin is intact, because, you know, you wouldn't really inject into skin that was broken or for any reason damaged. And in the adult OSCE, we would also mention tattoos, because the skin is scar tissued underneath, and we would probably choose another area. Talk about rotation sites as well. So if you can see, obviously, when we're doing insulin, which is one of the main drugs that we inject as nurses, we see a lot of areas that have already been injected in adults. In children, sometimes they have a very small cannula under the skin, and we use that to inject so we don't have to keep pricking the child. But if it's the case that they are an adult and we are going to administer insulin, we should really look for an alternate site for injection. And you will often give the injection into the abdomen in an adult. I think we're quite used to that, probably everybody, or the leg. In the OSCE, they may ask for you to administrate it in the arm, because the mannequin has injectable ports in the arm usually and in the leg. So that's in the upper thigh, obviously. If you're going to give it in the upper thigh, that's fine, if the mannequin has that injection point. If they don't have that injection point, it can be in the upper arm. So you don't need to locate the acromion process in the upper arm for subcut. That's for IM injection only that you're doing that. So for the subcut, you don't need to, just need to say that the skin is intact and it's clean. So when you're about to give the injection, you need to pinch the skin, because it's a subcut injection. If you're pinching it, you're holding the fat together, and then the injection will go into the fat layer. When you're giving IM, you need to stretch the skin. If you don't do that, they will say it's wrong route. So sometimes I see nurses not touching the skin at all and just giving the injection. That's not good practice, and it will get you failed. So if you're doing this particular station, subcut, they want to see you pinching the skin. Give the injection first, then give it over 10 seconds, and then you can release it and remove the needle. Do that quickly. You don't need to leave the needle in the skin for subcutaneous for any length of time. You're just going to count to 10 or more, but because it's usually a small injection, 10's fine. And then just put it straight into the sharp spin. The other thing is, these syringes do have safety catches, safety devices on them. These are more modern. So if we push that up after injection, that sharp is now safe and you cannot be injected with that. But the examiner doesn't want to see it in the tray. They want to see it going straight into the sharps bin for safe administration of safety of sharps. So don't put it into the tray, even though in theory it's safe. Put it into the sharps bin, please. The examiner can prompt you throughout with what's called trigger questions, and they can refer to things in the criteria which you seem to have forgotten. It doesn't mean they're going to tell you to put your apron on or sign the chart, but they can prompt you and say more sort of general questions that might make you think. And that's why it's so important before you go to any of these stations to have a really good idea of how you're going to perform it and be very, very conscious of each step of each skill. And the most important things with any medication charts and administrations are checking ID, administration technique, disposal of sharps, and then of course signing. Don't be explaining to the patient, giving them health education and not signing it. The health education doesn't even have a marking criteria against it, so you're not gaining anything from giving them health education, but you are by signing it. So make sure you sign it and date it and time it and do what's asked of you. Anything extra is just like extra, as in it will probably impress the examiner, but it's not actually getting you any more marks, which is what you're really after for a pass. The examiner would have told you with 5 minutes to go that you've only got 5 minutes left. And when you complete the station, which you should do within 12 minutes, and most people when we're practicing can quite easily finish this station within 12 minutes, they will say, have you completed the assessment? And you need to say yes at that point, and they will then say quite clearly that they will end the station. And again, they make a note of the time, and then they'll ask you to sit while they reset the station. That is an overview of subcutaneous injection, and I hope that has been helpful to you.